It's 17:01. Are we on, Steve?
Yes, we are.
Well, it's 17:01, ladies and gentlemen, and a good afternoon from a very chilly Cape Town. It was 2 degrees Celsius this morning and with snow on the Table Mountain. So we have clear skies and it's beautiful outside, except it's jolly chilly, and that's why I was wearing my puffer. With me this afternoon, my name is Peter de Jong. With me is Professor Stephen Jeffrey. You all know him, and he's not going to get an introduction because he's always been around, and I consider him one of the 10 best urogynecologists of Cape Town. So, ladies and gentlemen, our guest speaker this afternoon is none other than Professor Phil Steer. And Professor Phil Steer is an old friend of Cape Town. He comes here often. In fact, he's a university professor. And how do you say this word? Emeritus. I can never say that word. Emeritus Professor of Obstetrics and Gynecology at Imperial College in London. And importantly, he's revising his high-risk pregnancy management options Bible. This is the Bible of obstetrics, and he's been the chief editor for many, many years, for decades, in fact. He's a fellow of the College of Obstetricians and Gynecologists in South Africa and also in America. It's wonderful to have you here, Phil. And your title is Caesarean Section and Antibiotics Alter the Neonatal Microbiome. What does this mean for the future health of our children? A very important topic, and it's reflected in the number of people that have logged on today to be with you for this talk. Next week, we have Clayton Hall, approaches to dealing with medical negligence and other complaints against you. So we're going to start then without further waste of time, Professor Phil Steer. And it's wonderful to have you here, Phil. And we look forward to your talk this afternoon about the neonatal microbiome. Phil.
Thank you, Peter, and thank you, Stephen, for that kind introduction. And we're going to start by just doing a quick assessment of what people know about this particular topic. So there are 5 questions that we'd like you to answer, which should pop up on the screen. And then when enough people have answered it, we'll have a look at the results. So the first questions, you can scroll up. There's a little gray bar. You can scroll up to the top. Have you heard of the microbiome? Do you know how the neonate acquires its microbiome? Yes or no? Are you aware of the effective mode of delivery and antibiotics on the microbiome? If you're not sure, just say no, because we just want to get some idea of the background knowledge. Will altered neonatal microbiome have consequences for long-term health? This is of the baby we're talking about here. And do you know if there are strategies to safeguard the neonatal microbiome? And if you don't know, if you're not sure if there are, just say no. Okay, so if everyone can have a go at voting on that. We have to wait a little bit until enough people have answered. I should add that perhaps I can say that it's not 2 degrees here. It's 23 degrees in my office and outside. We're in the middle of summer, of course, or just at the tail end of summer in the UK.
Wow, that is a beautiful warm day in London.
It is. Wow. It was too hot yesterday. It was 28 degrees, which was a bit more than I like, but today's perfect.
Well, you'll have to go sailing, Phil. Every time I see these hot days, I think of you sailing. But then, of course, with problems that have happened on the big yachts, I feel for your safety.
Well, I've been through a few gales in the Mediterranean in my time, but luckily the boat never sank.
Yeah, but that's because during the gales, you actually close the hatches, batten down the hatches and put your keel down.
Well, that's true. That's true. Took the sail down and flip on, put all the wet weather gear and the life jackets and the whole bit.
The life jackets, and also you start your engines. Anyway, I don't want to be sidetracked.
Absolutely. How are we doing with the questions?
Wendy, can you? There we go.
There we go. With the answers.
Okay, so people have heard of it, but then only about 60% know how it acquires it. That's interesting. Are you aware of the effect on the mode of delivery? Oh, a substantial number aren't. Will it have consequences? Yes, well, we'll see. And lots of people don't know if there are strategies. So that's good. So hopefully I will repeat that at the end and see if I've changed anybody's views or knowledge in that way. So what I'll do now is I'll share my screen, and you should be able to see that now. Can you see my slides?
Not yet, Phil.
Can you now?
Now we can, yes. There we go.
Perfect. Okay, so there's my title. So what are the factors that we have to think about when we're considering the future health of our children? Well, obviously, genetics is very important. It's estimated that about 60% of our health is controlled by genetics and about 40% by our environment through encoding and alteration, methylation of the genes and so on and so forth. And that was covered by Professor Barker in Southampton, who developed the developmental origins of health and disease. So we know that it's what happens in the uterus and around the time of birth is important, and he put that on the map. Now, in terms of the mode of delivery, I'm just going to mention briefly stress programming, but I want to concentrate particularly on the microbiome and how the baby acquires it and what it means, and in relation as well to breastfeeding, which is also a very important component of transferring the microbiome. So, what is the microbiome? Well, it's actually composed of bacteria. Now, the Earth has been around for about 4.5 billion years, and the life on Earth has been around for about 3.5 billion years. And for almost 3 billion years of that, it was just bacteria. So multicellular life has been around for about 800 million years. So bacteria really ruled the roost for a long time, and they're still pretty well universal. You can actually find them 10K down in the Earth's crust. And some bacteria live permanently in the stratosphere, 10K up in the air. Amazing. So we're unaware of all these microscopic organisms, but they are profuse and they're all around us. And they're in and around the human body. And recent studies have made it clear that microbial cells, in terms of numbers, actually outnumber human cells by about 10 to 1, because they're generally quite small. Now, we've learned a huge amount in the last 10 to 15 years, and I just wanted to highlight one particular microbiome project funded by the National Institutes of Health in the USA, and highlight the fact that they've now referenced over 3,000 bacterial genomes from the human body. So we're not talking about the world in general. This is just us. We have 3,000 different bacteria that live in, on, or around us in immediate contact. There's been a huge museum, as it were, or profile of the microbiome from over 300 healthy humans. It's the world's only complete data set. Now, this is one of these horrible, complicated slides that people say, it's too complicated, it's too busy, I don't understand it. What am I trying to show? What I'm trying to show is, firstly, up at top left here, there are a whole range of particular microbiome areas where there are lots and lots of bacteria that are very important, preventing infection in the nose, in the mouth as well, the oral cavity, and the tonsils you all know about, unless you've had them removed like me as a child. Now, the main one that we're going to be concentrating on today is actually not, as you might expect, the uterus and the vagina, but actually the gut. And it will become clear why I'm concentrating on the gut. And what are all these numbers here? This is the incidence in the various biomes of all these different bacteria. Now, I don't for 1 second want you to start reading what all these bacteria are called. The main point is to appreciate just the whole range of bacteria that are involved. When, as gynecologists, we learn about microbiology, in the past, we'll have learned about simple things like bacterial vaginosis, trichomonas, thrush, group B strep, and so on. So we're used to thinking about single bacteria or single organisms. But in fact, what we need to now get used to is, when we're talking about these places and infections, is talking about whole colonies of bacteria, communities they're called, and these are called community states. So individuals vary in the balance of all the different bacteria that they have, and each of us has an individual balance of bacteria, which we call our community status. And so lots of work going on now, breaking down the various community states into major community states and minor community states and so on. And this just illustrates the distribution of the different bacteria in the different sites. Okay, so this is just to give you some idea of the complexity of what we're talking about. So we need to stop thinking about single bugs and single organisms and be concentrating now on talking about community states. Now, of the 5 human microbiomes that I've already described, what I want to concentrate on today is the gut. The gut microbiome contains about 100 trillion organisms in the human, and that's about 23,000 genes. The human genome is about 23,000 genes, as we know, but the gut microbiome actually contains about 3 million different genes. So you can see the relevance of the inheritance of all these different genes, which influence our health in many ways. Now, the sort of bacteria that live on us routinely, called commensal bacteria, do all sorts of important things in relation to absorption of the food in our gut. So they're related to the absorption of bile acids, lipids, amino acids, vitamins, and short-chain fatty acids. And without the bacteria in our gut, we would not be able to deal with any of these things properly. So that's why they're important. But a particular importance that I want to concentrate a bit more on, rather than just digestion, is the immune function. And we know that the bugs in your gut play a very important part in inhibiting the growth of pathogenic organisms. They tend to attack the nasty bugs that you swallow and overwhelm them and keep you healthy. So having a healthy gut microbiome is very important in not getting sick. It helps you to consume those critical nutrients that we've discussed, but also very importantly, each bacterium produces substances which act against other bacteria. They're called bactericidins. And they can modify the pH as well, in the gut, and they send signals to the immune system, your own immune system, so they regulate the innate and adaptive immune cells in your own body. Now, in the gut microbiome in the human, I want you to get used to some of these names. Don't remember them, but just some of them start ringing a bell. Firmicutes or Bacteroidetes are 90% of the type of bacteria. So what are Firmicutes? You've heard of some of them: Lactobacillus, Clostridium, nasty one, Enterococcus, some good and some bad, Ruminococcus, and so on. So that's Firmicutes. Bacteroidetes are things like Bacteroides and Prevotella. But there's another group, and this word is going to keep cropping up. So try and sort of keep this somewhere in the back of your mind. Bifidobacterium. It's part of the group called Actinobacteria. Bifidobacterium is one of the good guys. Lots of Bifidobacterium are good for you. They keep your gut healthy. So why is this all relevant to labor and vaginal birth for the baby? Well, there are lots of advantages of baby being born vaginally and going through labor. One of the important things, for example, is that the baby gets stressed. That produces catecholamines release in the baby. That programs the hypothalamic adrenal axis. And in fact, lung fluid reabsorption is triggered by the stress hormones that are released during labor. That's why babies born vaginally are much less likely to have problems with retained lung fluid, for example, and why we get the more problems with retained lung fluid at cesarean section. Also, there's a mechanical effect. Sometimes when the baby's head comes out, you can see the fluid from the lungs pouring out as the squeezing the chest results in less retained lung fluid. But what we're going to be talking about particularly now is that the baby acquires the appropriate gut flora from the mother. Now, why is this important? Well, during pregnancy, the placenta is pumping gamma globulins from the mother's circulation into the fetal circulation via pinocytosis across the placenta. This is an active process. So the baby has high levels of antibodies when it's born, and these, of course, will help to keep the baby safe during the first 2 or 3 months of life until they're eventually replaced by the baby's own antibodies, which take some time to develop. So this is a critical process. And how does the baby get the gut flora that it needs, its own microbiome? And in general, you can see here is a picture of a baby being born vaginally. They're mostly born occipito-anterior. The baby's mouth sweeps across the anus, and we've all seen the baby swallowing lumps of mother's poo and licking its lips, and that inoculates the baby's gut flora with the flora from its mother. Following vaginal birth, therefore, the newborn has antibodies appropriate for its gut flora. If you deliver a baby by cesarean section, it's not going to get those gut flora straight from the mother, obviously, because it's not passing through the birth canal. And the worst thing that can happen is that it gets somebody else's gut flora, hopefully not the surgeon's, but certainly if it's not the mother's, it can lead to long-term immune imbalance. This is what we think is the basic root of this problem. Now, I thought it would be interesting to comment on the issue of the rate of cesarean section. When I was born in 1947, the cesarean section rate in England and Wales was 2.5%. In other words, 39 out of 40 mothers gave birth vaginally, including my mother at home in my grandparents' house. And at that time, the perinatal mortality was 40 per 1,000. And you can see that as the time went on, by the time I became a consultant in 1981, the cesarean section rate had risen to the dizzying heights of 10% nationally. But look at the perinatal mortality. It had come right down to about 12 per 1,000 at that point. And we wrote papers at the time showing. So we got a dramatic reduction in the perinatal mortality rate, and that probably justified the rise in cesarean section rate. Now, by 1995, we've reached the 15% currently recommended as probably optimal overall by the WHO. But look at what's been happening since. The cesarean section rate has gone up inexorably, and it's still continuing to rise. The perinatal mortality, on the other hand, there was a change in the definition here, continued to fall, but only slowly. Okay, so it's now around about 5 per 1,000. So it's come down from about 8 per 1,000 to 5. So it has improved a bit, but at the expense of a dramatic increase in the cesarean section rate. Now, we don't have actually, tragically, very good national data in the UK, but I've managed to acquire this data from NHS England from the hospital episode statistics reporting. And you'll see that as recently as last year, the cesarean section rate overall, this is percentages, in England and Wales, had reached 39%. So that is compared with 2.5% when I was born. So we're aware that this is a growing issue. And at Chelsea and Westminster, I have to say, it's around about 40 odd percent. And in the private unit, I won't tell you what it is, but you can guess.
Double that.
Probably, yeah. Now, this is not just the UK, and I'm sure this is happening in South Africa as well, but this is a relatively old study. But even by 2012, there are all these countries which amount altogether to about 60% of the world's population, if you add them all up. Caesarean section rates greater than 30%. So we're reaching a situation where delivery by caesarean section has become probably globally almost as common as vaginal delivery. So we need to start taking this microbiome issue seriously. Now, going to the early noughties, I was actually the service director of our level 3 neonatal unit at the Chelsea and Westminster, and I was fortunate to be able to appoint Professor Nina Modi as one of the neonatologists. She subsequently became president of the Royal College of Paediatricians. So as you can imagine, we discussed this issue of caesarean section and the microbiome at some length. And together, we wrote quite a while ago now in the Lancet, 20% increase in diabetes associated with elective caesarean section in particular, not quite so high with emergency caesarean because there is some exposure to the maternal microbiome. But if you look at elective caesareans, 20% increase in diabetes, 20% increase in asthma, allergy is increased, obesity is increased, and there can be abnormal stress responses. So, why is this all happening? Well, we're now beginning to see from more recent papers, this is from 7 years ago now, one of the early papers showing that there was a variation in the infant microbiome by mode of delivery. So let's just look at the top 4 here. This is in vaginal delivery. So Bacteroides, Veillonella, Escherichia and Shigella, and Bifidobacterium. That's this purple one here. And as you can see, they are substantially reduced in babies delivered by caesarean section. So we reduced from over half to well under half. In particular, the Bifidobacterium is of concern. Now, this is a more recent paper from just 5 years ago. Again, and this shows very dramatically the group of babies delivered vaginally compared with those delivered by caesarean section. And you'll see here the most striking finding is a particular deficit of the Bifidobacterium. Now, by 3 weeks of life, it started to recover the levels of Bifidobacterium, and to some extent, there's been a resumption of the normal pattern, but there is concern about what's happening to the baby's immune system during this initial period, whether it's being programmed correctly or not. And what we're now looking towards is more studies of whether there are permanent long-term effects. We think there must be because of the effects on asthma, diabetes, and obesity. Now, this interesting paper looked at Bifidobacteria in particular. And why are they so important? And this name keeps cropping up because there is now growing evidence that if you've got a good colony of Bifidobacteria, they help you to reduce the incidence of all sorts of diverse diseases related to the gut, but also related to immune function later in life. These are the key species. You don't need to remember the names, but this is some of the names that will keep cropping up in the literature. And in general, the strains that you acquire as a child will be the same as those found in your mother's milk. Now, the importance of this is that it highlights the importance of breastfeeding as an adjunct to vaginal delivery and getting the correct microbiome. So we need to really look at vaginal delivery and breastfeeding, both as helpful variables in producing and promoting clinically useful microbiome. Now, I mentioned earlier that one of the things that bacteria do is produce antibiotic type substances against other bacteria. And bifidobacterium is thought in particular to be producing some antibiotics, lantibiotics they're called, against clinically relevant pathogens. This is a very recent publication. How does this happen? Why should we be worried about things like, for example, obesity in the microbiome? So what we see here in the control group, here's a mouse with a normal microbiome passed on to its offspring, and then you take the gut contents from that and give it into another mouse, and nothing happens. It's healthy. What happens if we give antibiotics after weaning, where the baby's already, where the mouse has already acquired the normal microbiome, no substantial effect? But if you expose a mother to antibiotics, in this case just low-dose penicillin, both during pregnancy and throughout weaning, then this alters the microbiome that the baby acquires by the effect of the antibiotics, and is associated with obesity in these particular mice. And the very interesting and fascinating thing is that if you then take the gut contents of this fat mouse and put it into a healthy mouse, it becomes fat. So this is really good evidence that it is actually the microbiome alterations which are ending up with obesity, causing obesity. Here's a particular study from relatively recently, looking at 3-year-old children in the USA. About a third were overweight and obese. And if they had these sorts of bugs, they were more likely to be obese. But if they had bacteroidetes, remember we've heard that word before, they were actually less likely to be obese. So again, good evidence that the bacteria that you carry in your gut are going to have an influence on your gut function, and therefore whether you become obese or not. Here's another study looking at a birth cohort of 935 babies, collecting fetal samples. If the babies were born to overweight or obese mothers, there was a marked effect on these two particular types of bacteria. Firmicutes were more abundant, and if babies were born to overweight or obese mothers, they were 3.8 times more likely to become overweight or obese. So it looks as though part of the generational effect of fat mums having fat babies is due to the fact they're passing on their fat microbiome. This particular study highlighted the effect of antibiotics, and it reported that if you exposed people to antibiotics in the mother's second and third trimesters, there would be an approximately 80% increase risk of childhood obesity. So this is substantial exposure to antibiotics. This raises the question of whether we should be giving antibiotics routinely at the beginning of caesarean section. Now, some years ago, the national guidelines in the UK moved from giving it after cord clamping to prevent infection in the mother after the caesarean, to giving it before the caesarean actually commenced, in the hour before the caesarean was started. And this was thought to produce a further small reduction in the incidence of infectious complications to the mother. But in this particular study, which was in Scandinavia, they looked at a very large series of elective caesarean sections where they compared with antibiotics after cord clamping. And they found that the incidence of serious infection was extremely low. And therefore, they suggested that we should in fact revert to giving the antibiotics after cord clamping to reduce the effect on the baby's microbiome. I've mentioned the importance of breastfeeding. Antibiotics in breast milk have also been shown to be important in producing an abnormal microbiome. And this particular study from Turkey actually reported that in 85% of cases, human milk samples contained evidence that the mothers had had antibiotics, cephalosporins. 14.5% were positive for quinolones. That's like ciprofloxacin, the second generation antibiotics. So we know that antibiotics are given very, very widely, particularly in developing and low-income countries, where they're used as a sort of panacea. This may not be having a good long-term effect on our population health. What about exposure to benzyl penicillin and gentamicin? There is now growing evidence that using these sorts of antibiotics, particularly gentamicin, will increase the incidence of resistant bugs in the microbiome. And this is particularly a potent effect in Caesarean-born infants. So selective antibiotic-resistant classes were present following exposure to antibiotics, both at week 1 and week 4 following delivery, so increasing the susceptibility of the baby to unpleasant infections. So they suggested in this particular very recent paper that antibiotic use is amplifying the resistome profile, so weakening the good bacteria to the extent that your resistance to nasty things like gut infections is going to be reduced. This is because it selects multi-drug resistant bacterium. And of course now the concern is that there's an interaction here between the antibiotics, delivery by caesarean section, and producing childhood obesity. So if we excluded the effect of antibiotics and just looked at caesarean section, this particular paper reported almost a 50% increase in the risk of obesity. But if you then added exposure to antibiotics, that went up to 84% higher risk. So these two factors interrelate with one another and interact. So we're messing around with the microbiome at our own peril. What about GBS prophylaxis? This is something I mentioned, this problem, in my previous lecture in this series. And there is some evidence that it is affecting the microbiome, at least in the first 6 weeks of life. But by 12 weeks of life, it seems to have recovered. And if you're just using penicillin, there is growing evidence that the effect on the microbiome is significantly less. What seems to be worse is using the broad spectrum antibiotics such as cephalosporins or the quinolones. Here's another relatively recent paper on bacterial count in IAP, but again, looking specifically now at bifidobacteria. And luckily, at 30 days, there was no differences in the bifidobacteria. You've seen that caesarean section, you've seen that caesarean section does have a dramatic effect on the bifidobacteria, but luckily, intrapartum antibiotic prophylaxis doesn't seem to have a similar major effect on bifidobacteria. And again, looking at IAP with penicillin, this is a paper looking particularly at the antibiotic-resistant bugs that can occur. They didn't find any significant differences. So we can be reasonably reassured that penicillin is one of the least damaging of the antibiotics that we can use, luckily. What about the long-term effect? Again, here's a nice reassuring paper suggesting that just using penicillin prophylaxis did not increase childhood obesity. So again, that's reassuring. So current evidence suggests that IAP for GBS does alter the microbiome, but at the moment, there's no evidence of a causal link as compared with caesarean section and broad spectrum antibiotics between the effects of that antibiotics and future ill health. But we clearly need to continue to research this. Now, here's an interesting finding just from July of this year, looking at the effects of COVID-19. Now, this is another wild card that's come into the equation because it's been discovered that individuals infected with severe COVID-19 often get a disrupted microbiome, and the diversity and richness of the gut microbiota are reduced. And this may be related to long COVID, which some of you may have heard of. Now, we know that the other important relationship between the microbiome and the gut and the brain is a critical role in neurodevelopment. This may seem quite surprising, but I've mentioned the effect on the immune system, so perhaps we shouldn't be too surprised. There seems to be a very important role here of that axis in promoting normal neurodevelopment. And if this is disturbed, particularly in the early postnatal period and then subsequently in puberty, then this will have important developmental effects. And there is now growing evidence that disruptions to gut microbiota during the early parts of life in the neonatal period predispose to mental disturbances such as schizophrenia and autism, neurodiversity, neurodiverse children. So we're beginning to see that long-term effects of disrupting the microbiome are not just related to the gut and digestion and immunity and obesity, but also more worrying things such as neurodevelopment. Again, a very recent paper highlighting that this is potentially a problem. Now, probiotics may be predictive. That's what they suggested in this paper. So let's just think about probiotics. Before we get to that, let me just remind you about the importance of breastfeeding. Breastfeeding interrelates with cesarean section. It provides an appropriate nutritional balance, and there's less childhood obesity. We've known this for a long time in women, in the babies of mothers who breastfed them. It is, of course, also an important source of antibodies directly from the mother. It will also inoculate much of the mother's bacterial flora, including some of her gut flora, interestingly. This is a very complicated diagram, and all I want you to notice is that when you have acute mastitis, you get a different microbiome than when you get a healthy breastfeeding, and subacute mastitis again is different. So again, there are now interesting studies looking at the influence of mastitis on altering the microbiome, and giving antibiotics to treat acute mastitis will compound the problem. So it makes it even more complicated. So we're beginning to understand there are ramifications to all these infections and their treatment on long-term health. And the longer the mother breastfeeds, the more diverse is the microbiome. So again, here, this is similar to one you've seen before. Remember the bifidobacterium here? This is in the purple. And you can see that in babies that are breastfed for at least 6 months, more than half of them will have the good bacteria colonies. The community states are good. And this is reduced in babies that are not breastfed for that length of time. So again, we're finding the effect in relation to the duration of breastfeeding. And unfortunately, we know that low breastfeeding rates are associated with poor socioeconomic status, poor diet, and obesity, etc. It's associated with ethnic minorities in developed countries. And also, of course, if you deliver by elective cesarean, we know for all sorts of complicated reasons that reduces the breastfeeding rate. So these all gets rather complicated. And these adverse effects all start to feed into one another. How are we going to deal with this? Well, there were suggestions when this all first came to light about the microbiome that we could actually seed the baby with the correct microbiome if it was delivered by cesarean section. What did this paper suggest? If your baby is born via C-section, consider taking a swab of your vaginal secretions and rubbing it on your baby's skin and in her mouth. Now, when I was giving some time ago cesarean section lectures, I actually said that the surgeon should think about, when he's finished the cesarean section, putting his finger into the mother's anus and then sticking it in the baby's mouth. And this was meant to be a joke about transferring the microbiome, but then I discovered that somebody took it seriously, so I don't say that anymore. So don't do that. And in fact, a series of papers, firstly, one paper suggesting that giving the mother's poo to the baby might be useful. There was this paper way back in 2016, was immediately followed by an editorial in the BMJ saying that this was a bad idea because unfiltered poo can contain group B strep, herpes simplex, chlamydia, and Neisseria. So this is obviously not a good thing to do. So simplistic solutions are not there. We don't have simplistic solutions. So what probiotic approaches might we employ? Trying to give babies good bacteria. Well, it was defined as long ago as 1988 as an organism that confers a health benefit beyond the normally acquired nutrition. So you add it to the normal diet to get better health. But they pointed out then, back in 2000, then this is not that long ago, 2018, 2018, this paper pointed out that the research on this remains very poor. How might this work? Well, people have been trying giving lactobacillus and bifidobacterium. You remember that one? That name keeps coming up. Hopefully you'll remember that now for the next few months. Bifidobacterium, that if the mother eats it, gets into her gut, she can transfer that possibly to the baby during pregnancy, but more likely during delivery, and then through the breast, through the breast milk feeding, she can get it into the baby. And this would produce ideally balanced immunity. So that's the idea, but this is just a couple of different sorts, not the widespread variable community that we've been talking about. And people have been looking at this. Here's one paper where they did a randomized controlled trial of women who had cesarean section, and they gave a group of bacteria, and they claimed that supplementation, or they reported, not claimed, they reported that if you supplemented the mother orally with bifidobacteria, this normalized the baby's microbiome. However, a more recent randomized double-blind trial used a labeled bacterium, in this particular case a lactobacillus, compared it with placebo, and actually they discovered that they were looking at rates of bacterial vaginosis, no effect found on that. And then if you looked at the randomized controlled trial of giving bifidobacterium to the mother, it only passed on in 2 out of 65 babies in the mothers given bifidobacterium. It was a specially labeled one that they could detect. So this was not encouraging. There were none in the control group. So getting 2 out of 65 wasn't a very promising result. So we've got a lot more work to do on this. This is quite a recent paper. This is still data coming out. But as usual, the pharmaceutical companies are not waiting for the research. They're getting in on the act. And this particular paper from 2023 reported that last year, 1 in 5 of French NICUs and 100% of Swiss NICUs were already routinely giving newborn babies probiotics. And it'd be interesting, I should have asked that as a question actually, whether any of your neonatal units are routinely using any of these. These are just a sample of what are on the market. Unfortunately, there are no guidelines relating to the use of probiotics currently that I'm aware of. We don't know which bacteria should be in there. Should it be bifidobacteria? Should it be lactobacillus? What should it be? There is insufficient scientific evidence, in my view, to make recommendations. And there are also concerns regarding potential adverse effects of giving the wrong microbiome. I mean, that's clearly a significant risk. So what are my conclusions? Well, I hope by now I've convinced you that the microbiome is an important factor in long-term health. I think we all really have to accept that. But the important point is that it's a complicated thing. It's very variable. We all have our own individual microbiomes, and they vary between families. The community states that are common in one family of people may be different to those in another family of people. They need to be attuned to the genetics of the host. So it's not one size fits all at all. Mode of delivery and use of antibiotics perinatally, particularly perinatally, are potential disruptors of acquiring a normal microbiome, and these have long-term effects on obesity, immune function, neurodiversity, and so on. There is a potential for probiotics to help restore the balance, but I think that what we may need to be doing in the future is actually analyzing the mother's microbiome before the baby is born, if you're going to do a cesarean section, and then it may be a question of the clever pathologist concocting a cocktail of appropriate probiotics to give to the newborn baby so that they match the mother's antibodies and are as similar as possible to the mother's microbiome. Now, clearly that's not going to be easy or cheap. So perhaps in the meantime, we can actually safeguard our babies by not doing cesarean sections when they really are not necessary and not giving antibiotics when they're not absolutely indicated. So I'm going to leave you just with some pictures of the birthing rooms at the Chelsea and Westminster Hospital. And let's think about stop sharing and doing again, see if I've changed the answers to the 5 questions. So let's have a look at those and then we can perhaps discuss.
Okay, Wendy, if you can just show Professor Steer's questionnaires, please. Thank you.
Now, while people answer those, we do have again, Veronica, because there's only one question from her about, but and I think it was answered in towards the end of your talk. What about giving probiotics or prebiotics a few days before the C-section? And again, and then all the baby post C-section. But I mean, you mentioned that we're not quite there yet in terms of what we would be able to give her.
No, it's clearly a very fertile area for research, but I suspect, for reasons that I hope I've made reasonably clear, it's not going to be a simple one-size-fits-all solution. I don't think there's going to be a magic probiotic that we can give to all babies, or indeed to all mothers during pregnancy that will do the trick. I think it'll have to be attuned. What's the right probiotic for one mother and baby may not be the correct or the optimal probiotic for another. And that will be the challenge. A little bit like in cancer treatment now, we're going to the individual genetics of the cancer and developing individual vaccines. I think we're going to have to go to the individual genetics of the microbiome and the genetics of the bacteria to produce something that's suited to each individual baby. That's presuming that we go on delivering half the mothers by Caesarean section. We're going to need this.
Yeah. Professor Steer, just while we're waiting for your questions to come through, what I do at Caesar is we don't use a routine antibiotics until the baby's cord's been clamped.
Right.
And as soon as the baby's out, within the first 10 minutes, we would ask the mother to have skin-to-skin contact and to breastfeed.
Yes.
Whilst in the room. So at least you have, number one, you don't destroy the baby's microbiome, and you do enhance it perhaps by breastfeeding and also by skin-to-skin. I'm not sure what effect skin-to-skin has, but I'm sure it isn't necessarily deleterious.
Well, it depends, of course, on the mother's standard of hygiene. It's one of those situations where perhaps assiduous hand washing and cleaning the nipple and all that sort of thing may not be ideal. We want perhaps a minor degree of contamination of the normal of the breast with the normal microbiome, but that's a tricky thing to arrange.
Yeah.
Now, there's actually been an interesting question by Almra for you about really the whole concept of the baby being exposed to the mother's fecal contents at vaginal delivery. That's the essence of the question here. And why that is okay versus, someone doing a forced sort of seeding with a C-section. What are your thoughts on that with the maybe less dose of the vaginal delivery? I don't know what, what are your thoughts on that one? He's basically said he doesn't really follow the concept.
Just summarize that question again for me.
So it's not a very clear question, but basically saying I don't follow the warnings against vaginal seeding when babies are exposed to exactly the same possible bacteria or viruses with vaginal delivery.
It probably would be perfectly okay in 95% of mothers and babies. The problem is that if the mother's got an infectious condition, I mean, if she's got Neisseria gonorrhoeae or she's got HPV, you don't want to be transmitting that to the newborn baby, and that's the problem. I guess if you screened the mothers assiduously for STDs and so on and so forth, then you might be able to use her microbiome directly in a relatively safe manner. But I'm not sure I'm aware of anyone who's advocating that at the moment.
Well, Professor Steer, you've got your answers. Should we go through?
Well, I'm pleased that people seem to have we seem to have switched a lot of people into knowing about it.
Yeah, definitely. Highly significant improvement.
Will altered neonatal microbiome have consequences for long-term health? 100% agree.
Well, I think you swayed them by your eloquence there.
Yeah, well, I think, but it's an important message that we leave with people, that the Caesarean section, obstetricians are very familiar with the long-term effects on the mother in terms of repeated pregnancies, placental accreta, and so on and so forth, and the surgical complications. But I still think that currently obstetricians are not sufficiently aware that perhaps even more significantly, in terms of the species, there's a long-term effect on the child of being delivered by Caesarean.
Yeah. So that's certainly an area we should focus on, given the very high Caesarean section rates.
Correct.
And the effects that these might have on long-term neonatal health, ne?
Yeah.
Yeah, I
I
mean,
think
when you're discussing a cesarean section with a mother who requests one, for example, so it's maternal choice, I think now it would probably be considered substandard practice not to explain to the mother that there are not just effects on her, but there are potentially significant long-term effects on the baby. And
Yeah.
now, if you've listened to my lecture, you have no excuse for not explaining what they are.
yeah, it's good.
Yeah.
Yeah.
Steve?
Yeah, no, I mean, I think it's this is such an important topic. Those of us who see patients with recurrent urinary tract infections, we see more and more that we're chasing our tail with a lot of these patients because they get a UTI and then you give them antibiotics, and I think you're completely disrupting their body's
Yeah.
own ability to resist the infection because you're disrupting that very important microbiome in the rectal area, in the vaginal area. So, and one of my patients went so far as to get a fecal transplant, which, I mean, is also, again, a very interesting topic, which we don't really have time to talk about. But after a few admissions for recurrent UTIs and very bad Klebsiella, she ended up going to one of the local people who's doing this very controversial treatment.
But why is it
But-
controversial, Steve? It's
No,
it's
I don't think-
it's not controversial. All right, UTIs aside, we've heard the evidence over here how important a healthy, balanced microbiome is. And if a woman, just as you say, a bit left of center, off piste, if she has inflammatory bowel conditions, for argument's sake, why is it dangerous, in your opinion, to not give her a healthy? And also on that topic, there have been some Israeli work saying that if a woman has chronic discharge, you can give her a healthy vaginal biome as well. What do you feel about that, Professor Steer?
Well, it comes back to defining what a healthy microbiome is, and it's not the same for each for different people. This is the fundamental problem. So we're just beginning to look. I didn't want to put up even more complicated charts, but looking at for example, 5 different colony states or community states, they're called, and people are now looking at the implication of those community states for things like preterm labor, and so on and so forth. So we've got a long way to go in understanding what the balance between these different organisms is optimally and how that relates to each individual's genetic profile.
Yeah. So I mean, just to talk to your question about the fecal transplant, etc. I mean, I just think it's such it's still so much in its infancy. So to do it in a controlled fashion and to know what to do and how to give it. I mean, one of my patients went so far as to order some fecal capsules from I think Turkey or Holland, and they post them to you, and so it's there isn't a big industry out there.
Those things taste terrible. They taste like shit.
Well, was that for the mother or for the baby?
Well, this is more from we're talking more from a gynae point of view and recurrent UTI. So this is not an obstetric indication, but people are noticing an issue, and I think that it's a big thing in treating patients with these chronic conditions.
How can you improve chronic urinary tract infections by taking a fecal oral ingestion? That's the question I want to know.
Well, I mean, I think as you vary there's a few studies that have started to look at the diversity of bacteria in patients with recurrent urinary tract infections, and it's much lower in those patients. So,
really?
Yeah. And it makes sense that, obviously the better your community, and I mean, I'm very interested to hear your views on this as well. The better the variation, the better your resistance. And I think we'll definitely see a lot more on this. I mean, again, also with your chronic vaginal discharge, I know about that research that's happening in Israel. I think it's in Jerusalem, in Hadassah University, where they're looking at chronic vaginal and the vaginal microbiome as well.
Well, there's microbiomes everywhere. You get a placental microbiome, you get a microbiome almost everywhere in your whole body. Isn't that right, Phil?
Yeah, I mean, just coming back to the issue of fetal transplants, it's an interesting fact that in the UK, the blood transfusion service has a fleet of specialist motorcyclists who carry the blood around because they can get through the traffic much more quickly in an emergency. And the only other thing that they regularly carry, other than blood, is actually fresh fecal samples for fecal transplants for people with Clostridium difficile and other major conditions where their own microbiome has been destroyed by prolonged antibiotic treatment or other immune conditions, and they need to reestablish a healthy microbiome. And there's no doubt that in those situations, a fecal transplant can be very effective.
Yeah, I mean, there is someone in Cape Town doing that and it's a gastroenterologist. They actually put it in through a gastroscope.
Gastroscope.
Yeah.
There are variations on this thing. If you go onto the internet, there's a turkey baster that can do it for you. Shall we just look at that question? Guidelines still recommend antibiotics prior to skin incision at Caesarean section. Should we change practice now?
Yeah, I think if you're in a practice where your incidence of complications is low, then I think it becomes a valid proposition to say, let's wait until the cord has been clamped. That was always my preference. That was always my practice. And when it changed to giving it preoperatively, obviously the anaesthetist did that, and that became but I was always slightly nervous about it because in my experience, preventing relatively minor skin infections in the mother wasn't to me a huge priority compared with flooding the baby with antibiotics. Within 45 minutes, the levels of antibiotics in the baby are similar to those in the mother. So you're giving the baby a pretty big slug of antibiotics.
Yeah.
It always worried me that, if you don't need to give these things, don't. It's another good reason not to give women antibiotics antenatally for proteinuria without any proven infection, for example. There's a tendency to think, oh, just give them some antibiotics in case. Well, it's not a good idea, in my opinion. If you don't need to do it, don't do it.
Yeah.
Well, the use of antibiotics is far too widespread, and there's many calls to reduce it because of the possibility of antibiotic resistance. So I think that we've been far too, especially family physicians love to do that, Phil. If a woman goes there and she's got a couple of leukocytes, they would label that as a urinary tract infection and then flood her with oral antibiotics, which I think is not useful.
No, but I think just destroying the microbiome of the patient is probably for me almost a bigger issue. There's a personal health benefit to not get antibiotics, and so that's something I try and motivate to my patients now when they ask for an antibiotic. And the whole issue of resistance maybe being a secondary issue, which is a more global issue. But yeah, thanks. I mean, it's been a wonderful discussion, and I think this is something we're going to hear more and more about in the next few years. It's only still in its infancy. I look forward to a lot more guidelines related to a lot of this stuff. And
I think it'll take a while to filter through, but I think it will come through. And I think that first suggestion you made about giving the antibiotics after skin incision, that's low-hanging fruit. That's very easy to implement, and that has obvious improvements. And then perhaps breastfeeding with skin-to-skin contact. Look, our patients get given a Hibitane shower the night before a Caesar, and I'm not sure that would make or not make any difference to their biome or their level of hygiene at all. But it sounded like a good idea. That's the problem. Many of these intuitive responses sound like a good idea, like your idea, Phil, of the surgeon putting his or her finger in the mother's anus and putting in a nice pink little bottle and letting the baby suck on that.
Well, maybe you can give the baby to the father to skin to skin. I mean, I think that's actually quite a good idea too.
Well, they do it over here. I'm not sure it's useful or appropriate, but
well, the father may not have the same microbiome as the mother. You got to be careful about that.
That's the point.
Okay.
It's not just a question of any old microbiome. It's got to be the right microbiome. That's the point. It's this balance. It's this match between the antibodies that the baby has, and if it gets the mother's microbiome, you've got a perfect match because that's the way that the mother lives. And as soon as you change it, it potentially is deleterious. Anyway, I think the long-term implications of the Caesarean section rate are only just beginning to become apparent in terms of obesity and long-term problems. Abnormal neurodiversity and so on is beginning to rear its ugly head. So if you want to hear more about that, come to the refresher course next April at Cape Town, because I shall be waxing lyrical about it there.
Good.
That's wonderful. We hope perhaps you'll be able to come to Figo and give us the gospel in October next year as well, Phil. We'll get the scientific committee to invite you.
Anyway, thanks so much. Yeah, that was a wonderful talk. Again, really stimulated a lot of discussion, a lot of thinking, and I'm sure it's going to change practice in a lot of the way we do C-sections. And I think that's going to make a big difference. So thanks so much.
All the very best, Phil. It's been wonderful hearing you again. Thanks once again for you appearing on this platform, and all the very best for enjoying the last of the British summer before winter sets in. And we look forward to seeing you. Did you say April you'll be here at the UCT
Yeah.
refresh course?
Yeah, yeah.
Okay. See you then.
28th to 30th.
Are you speaking on these topics then? The microbiome?
Well, I'm going to talk about the long-term effects of the high Caesarean section rate. And of course, that will involve the implications for altering the microbiome.
So Phil, just about that, there's been one question I didn't bring up. It says, what evidence is there? What hard evidence is there? I'm quoting that the 15% Caesarean section rate is optimal. Where does that come from? So maybe you'll tell us at the UCT refresher.
I will indeed.
Okay, thanks very much, Phil.
Thank you.
God bless, Godspeed. Thanks once again, and thanks for your time.
Have a great evening.
You too.
Thanks for
Thank you very
inviting
much.
me. Bye.
Thanks, Phil.
Bye. Cheers.
Goodbye.
Bye. Bye.